Hey everyone, I'm Ariana Parks, physiotherapist, and today I interview Gwendolen Jull, and she's going to talk about management of idiopathic neck pain, the need for a multimodal approach. Gwen is an emeritus professor in physiotherapy at the University of Queensland, Australia, and has published over 350 articles, 40 book chapters, and as well as 3 textbooks. In our discussion today, you are going to learn about idiopathic neck pain and its symptoms, what she found researching about the topic over the years, assessment and management of neck pain, and how to prevent recurrence. So if you feel this information is valuable, please consider subscribing to our channel, clicking on the bell so you don't miss anything, give us a thumbs up, and share with other clinicians you feel might benefit from this conversation. I hope you enjoyed the show. 𝗙𝗲𝗏𝗏podcast is only possible with the support of the forward-looking and innovative company Systems for PT, the Do Anything, Anytime EMR. Systems for PT develops systems for clinics so you can focus on your patients. Go to systemsforpt.com to schedule a demo today. Hi, Professor Gwen. Welcome to PT Pro Talk. How are you today?
I'm very well, thank you.
Awesome. So let's get started. And for the ones that don't know you, could you tell us a little bit about yourself, your background, and how did you get to where you are right now?
Well, my full name is Gwendolen Jull, J-U-L-L. I'm currently an emeritus professor at the University of Queensland in Australia. A little bit about my background. I graduated quite a long time ago now. I was initially a clinician, and then I had the opportunity, after I'd been out about 8 years, to study under 𝐓𝐚𝐥𝐤 in manipulative therapy. And so that really sparked my interest in musculoskeletal physiotherapy. And at the time, things were changing in Australia. We became first contact practitioners. And so that meant that the curriculum had to be developed more at the university. So I was invited to join the staff of the University of Queensland. And I subsequently spent about 35 years there. So I've had an academic career, but it has involved clinical practice, research, as well as teaching. So from the clinical point of view, I eventually did my specialisation with the Australian College of Physio. So I'm a specialist clinician, musculoskeletal physiotherapist. From the academic side, I did my master's and my PhD. And then I taught in the area of musculoskeletal physio at uni and indeed internationally. And from the research point of view, my major interests were in neck pain. So we're interested in differential diagnosis, in looking at what happened to the neck when people got pain, looking at the different systems in the neck. And also I've run a couple of clinical trials in the management of neck pain. So that's about it.
Yeah, that's a lot of experience, many years, and I know you published many papers. So let's talk a little bit more about neck pain that I know is your area. So how would you define idiopathic neck pain?
Idiopathic neck pain is probably a medical term, and by strict definition, it means it's an unknown cause. And so often you see now it's either called idiopathic neck pain or non-specific neck pain. And it basically says that it wasn't caused by trauma. And if we do a plain X-ray, for example, we can't see anything that might be the cause of neck pain. So they call it idiopathic or non-specific neck pain. But as physiotherapists, we look at it very differently. And so, if we assess the patient and we look at how the pain or the little injury or whatever it was, the overload, how that affected the musculoskeletal system, if we look at it by looking at the different impairments in the movement system, in the neuromuscular system, or the sensory motor system, that's the way we understand neck pain. And when we look at it from that point of view, things aren't unknown. We can be quite specific about what's happening with the patient, and then that can direct our treatment.
Yeah. I was going to ask you what are the symptoms, but I guess it depends a lot depending on the cause. How would you describe that? Do you have specific symptoms?
Yeah, the symptoms of neck pain, first of all, it depends on what level of the neck has been strained. So, for example, if you've got a strain, whether it's from your occupation or you've got an older person who's got a little bit of osteoarthritis, if it affects the upper part of your spine, you normally have upper neck pain and then headache. Whereas if you've got a problem with your mid or lower cervical spine, then you'll get neck pain and you'll start to get arm pain or pain down into your trapezius scapular area and then down into your neck. And of course, if your nerves are irritated, you can get that radicular pain, so the nerve pain down your arm, etc. So that's probably the most common areas of pain that you'll get with a neck disorder. The other thing too to remember, that neck pain patients can complain of other funny sort of symptoms such as lightheadedness or even a little bit of dizziness. They can complain of unsteadiness, sometimes blurred vision, and that's when they have problems with their sensory motor, the cervical part of the sensory motor system. So there can be lots and lots of different sort of symptoms that can be attributed to the neck.
And I know you research a lot of the impairments on neck pain. And could you tell us a little bit about what you found?
Yes, it's been an interesting area of research. I'm not sure if you know a person called Vladimir Janda, but he was a physical medicine doctor in Czechoslovakia, and he operated. Well, he's unfortunately he's passed away now, but he looked at the muscular system. And as far as neck pain was concerned, he was very, very interested in the deep muscles. And he would always say that the key muscles in the neck were the deep neck flexors. And so that started to get our interest in looking at the muscular system, not as a whole, but as different layers of the neck muscles. And so when you think about it, taking the neck flexors, where we've done an awful lot of research, but there's almost two layers. So your more superficial layers are muscles such as the 𝗔𝗯liche𝗪𝗪mastoid and the scalenes, but the 𝗔𝗯liche𝗪𝗪mastoid. Now, the 𝗔𝗯liche𝗪𝗪mastoid is a very powerful muscle, and it basically allows us to keep our head upright. But if you think of its anatomy, it's attached to the mastoid process and down here onto the sternum, so that it's nowhere near the actual cervical vertebra. So while it's a powerful muscle, and if we want to lift our head off a pillow, it does about 87% of the work, but it can't actually support the actual cervical vertebra. So if we go to the deep layer, like longus capitis, longus 𝐏𝐿𝐼, and in the extensors, multifidus, semispinalis, cervicus, those are the muscles that are attached to the vertebra directly. And multifidus goes from one vertebra to the next. And the same thing with the longus 𝐏𝐿𝐼. It connects the different vertebra. And so they're the muscles that have got the potential to actually support our neck or to support the joints of the neck. And then what we found, Janda had a clinical theory, but we were able to test it in the research laboratory. And what we found was that people with neck pain, they got an imbalance between the layers of the muscles. Okay, and so basically what happened was that what happens is the deep muscles get weakest first. And so we developed what was called the craniocervical flexion test, which is just testing their ability to nod their chin, but that's the anatomical action of the longus capitis and longus 𝐏𝐿𝐼. And we found in neck pain patients that they were very weak. They really could not do that contraction. And so we developed that craniocervical flexion test. We validated it. We did an experiment because using EMG, we had to develop an electrode that we literally built in a nasopharyngeal catheter and put it through the nose and suctioned it on to the back of the neck, because that sits right on the longus capitis 𝐏𝐬𝐿. Now, we had to do that because we can't use fine wire electrodes. They are literally, it's too dangerous an area with all the lymph nodes and everything. So we had to use, an alternate device. But we were able to show with the EMG that there was much more activity in neck pain patients. There was much more activity in the sternocleidomastoid, and it shouldn't work. I mean, it's not. It's actually a craniocervical extensor. So if we're asking the patients to flex in a lying position, it actually shouldn't work. But what we noticed in the neck pain patients is they couldn't activate their deep neck flexors very well, and so they overused their superficial flexors. And so we also, other people have done research in this area subsequently. So there's some research in Belgium with ultrasound, and again, they were able to show that, they couldn't get that contraction of the deep muscles very well in neck pain patients compared to controls. And then some other research is also showing a similar type of thing happening with the neck extensors, like the deep muscles. All the muscles will get weak, but the deep muscles get relatively more weak than the superficial muscles. Okay, so I suppose that was one of our major areas of research, was showing that there was an imbalance between these layers. And then we started asking the question, well, so what? What does that mean for rehabilitation? And what we found was, if you just did head lift exercises or general exercises, that the sternomastoid, for example, was very, very happy to work, but the deep neck flexors didn't work. And so that's where we started on this rehabilitation, which I can talk about later, where we look at activating those deep muscles first and getting the balance right between the two layers, and then we can exercise the whole system. But you've got to restore that balance between the muscle layers. So we call it improving their motor control before we get on to, before we get on to strengthening, etc. The other work we did, and this work was led by Julia Treleaven. We looked at the sensory motor system. So we were noticing that, quite a number of patients would complain of this unsteadiness or lightheadedness. And so for balance and that sort of thing, we need our vestibular system, our visual system, as well as our proprioceptive system. And so that led to research which Julia Treleaven has been the lead on, but looking at cervical-related disturbances in sensory motor control. And again, she investigated tests like the joint position sense test, balance tests, eye movement tests. And again, we were certainly finding in patients who complained of these symptoms that they had disturbances in these systems, I should say, which again gives us indications on what to rehabilitate.
I think one of my questions were, why do you think that these deep muscles get weak? Is because of pain and people don't want to move as much? Do you have any theory for why they get weak?
I don't think it's just pain and not moving, because if they don't move, all the muscles will get weak. We think that the pain in that affects what we call the anti-gravity muscles first. Okay, so another person that I worked with originally called Carolyn Richardson, and then later Julie Hydes, they did a lot of they did a lot of work looking at these muscles in astronauts. And what they found, now their work has mainly been in the low back, so they haven't looked in the neck as much, but the system in the low back is similar. Like, for example, in low back pain, the multifidus wastes and gets fatty infiltrate much faster and to a greater extent than the big, strong 𝗓𝗏𝗏𝗏 spinae. And what they found in this weightless situation, or when people didn't use their anti-gravity muscles well, like the astronauts, that they got selective weakness, not of the muscles that move them, like 𝗓𝗏𝗏𝗏 spinae or 𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏, but in those deep muscles such as multifidus. So whether it's some quirk of anti-gravity function that we don't use them, or they get inhibited, we know they get inhibited with pain. Why pain selects them first, probably we don't know 100%, but it certainly affects the anti-gravity muscles, and they're the deep muscles that hold us upright.
Yeah, it makes sense. And I think that was very interesting too, that relation about the sensory motor control with pain, because now I want to know, like, in practical terms, so what does it mean? So in your assessment, what do you need to pay attention when you are assessing someone with neck pain to address these problems?
Okay, assessment. Now, I've just talked about neuromuscular and sensory motor systems, but when we're thinking of assessing the neck pain patients, obviously we're going to take a history in the interview first to understand their neck pain, because one of the most important things in assessment is to look at what are the provocative factors. So, we're sitting, we're using devices, we're on computers, we're on phones, etc. So we've got to look at what the patient is doing and what are those aggravating factors, because unless we can modify them, we can do wonderful things for the patient, but if they go back to doing those provocative things, they're going to get their neck pain again. And the interesting thing is that no occupation escapes neck pain. Doesn't matter whether you're in the professions, like neck pain's really, really high in dentists. It's really, really high in plumbers who get their necks into weird positions. It's high in hairdressers, etc. So all occupations get it, and you often see that it's related to their either sustained postures or awkward postures. We've got to understand those work practices. So it's putting it all into context first. If I just, the other thing too, there's been a lot of interest in recent years in the psychological factors of neck pain. You should assess the patient, or we're just in talking to them, understand any anxiety levels or what their concerns are. But I would stress that a lot of those being anxious, being a bit fearful, are very normal reactions. I think it worries me that people are thinking that they are abnormal. They're not. They're normal. If you've got a pain in your neck and it's stopping you from working or it's stopping you from doing your normal activities, of course you're going to be anxious about it. That's normal. And the thing for us is that we've got to be able to assure the patient. And also you'll find if you get there's several studies now that show that if you get the pain better, the anxiety goes away or the fear goes away. So I think you've got to understand that, but also know that it's normal. Now, when we assess the patients, from my point of view, it's very, very important that we assess all systems. So that I'll start off looking at posture. We know, for example, physios always like the forward head posture. We get a bit fixated on that, but the studies are actually showing that the static structure, your static shape, is not necessarily related to your neck pain. So the people with neck pain may have a forward head posture, people without neck pain may have a forward head posture. So we've got to sort of prove whether or not it's related. The same goes for scapular posture. A lot of people get quite carried away if their scapula aren't perfectly aligned. But just because they're not perfectly aligned doesn't mean that they've got anything to do with the patient's neck pain. So we've got to make the observations of posture, but then I think the key point is that you've got to correct the posture and see if it changes their neck pain. So if they're sitting there, I often use just the movement of rotation and see if that hurts them. And then I'll correct their posture and see if that changes their neck pain. Or I'll correct their scapular posture and see if that changes their neck pain, because that gives you some knowledge of the relationship. We did a study recently. It was conducted by a PhD student from Thailand, actually, and she showed that probably about half of the patients that we see who have altered scapular positions, about half of them, you could change their neck pain by correcting their scapular posture. Okay, and the most common scapular posture.
That's crazy.
Yeah, the most common scapular posture that was related to neck pain was the downwardly rotated scapula. And so the things there was a bit of a pattern. Those people who when you corrected their scapula, it relieved their neck pain. They usually had upper cervical pain and headache. So it was this pattern. And if we think of levator scapulae attaching to the transverse processes of C1, 2, and 3, and it's really overworking, and they're almost hanging on that muscle, it puts massive compressive forces through the C1-2 joint, which is a real headache joint. So we've got to look at their posture and then change their posture to see if we can change their pain, and that gives us an indication of what we're going to treat. And then for the articular system and the movement system, we need to look at their movements, and that's a very, very important part, because I'm a firm believer that the origin of a lot of the neck pain, a lot of things can get painful, muscles can get painful, everything can get painful, but the root cause of their neck pain is often articular. Okay, so it's the joint that gets quite sore. So our examination of that movement system and the articular system is extremely important. And the reason I say that is the studies that look at either radiofrequency neurotomies or they inject local anesthetic into joints, it often eliminates pain. So as I said, while muscles can get painful, the nerves can become painful, lots of things become painful, I often think the main cause of significant neck pain is coming from the joint. So we look at their movements. We've got some validated tests, by the way, such as the flexion rotation test that 𝗏𝗏 has researched. So the flexion rotation test is very, very good at telling you if they've got C1-2 dysfunction. So that's a simple test. It's often done in lying, but you can do it in sitting by just getting the patient to bend their head forward and then rotating. Because when you bend your head forward, that's mainly taking up the movement in the lower cervical spine, so it leaves C1-2 free to move. So we can look at the flexion rotation test. The other movement test that's been validated is the extension rotation test, and that was done by a man called Greg Schneider in Canada. And the extension rotation test, you extend and rotate them just down to each separate level. And he validated that in combination with manual examination could accurately find 𝗏𝗏𝗏𝗏 joint problems. So we've got lots of movement tests. Remember, if we've got arm pain and we can't differentiate whether it's coming from irritation of the nerve, we can do distraction tests, compression tests. So there are lots of tests. And then manual examination to look at each joint separately. To me, that's one of our most valuable tests. It requires good handling, and I suppose if you've been following some of the internet discussions, manual therapy and manual examination have got, there's been a lot of criticism of it. But it really is very ignorant criticism, very, very ignorant. If you look at the real evidence, first of all, manual examination has been proven to be very effective, or to be very accurate when it's been tested against nerve or joint blocks. So there's 3 or 4 studies that have done that to show that it's quite accurate. And then if you look at the treatment of manual therapy, there are many clinical trials showing that it's very, very effective in treating neck pain and headache. So I do get rather disappointed with it's the ignorance. It's the ignorance of the debate on the internet, because manual therapy is a very, very helpful therapy to have. But all you have to do is look at the evidence. You look at the evidence. And if you look at clinical practice guidelines for the neck, they still advocate multimodal management, to use manual therapy, exercise, education. And as I said, if you look at the studies that have tested the accuracy, not the intertherapist reliability about what rate of motion, that doesn't work. The tissue changes very regularly, so it's not surprising. They are not good research questions. But if you ask the question, can manual examination find the symptomatic joint, or is there a symptomatic joint or not? Manual examination is very accurate. So as I said, I get very annoyed at the ignorance of the comments on the internet. However, we've also got to look at the nervous system. So, if the patient's got arm pain, all physiotherapists will do a neurological examination, and we've also got to look at any nerve tissue sensitivity. So we do our upper limb neural provocation tests. And then routinely I will look at the muscle system. So I'll do the craniocervical flexion test in a lying position. And so it's a very low load test, okay, because the patient's lying on their back. We use the pressure biofeedback to just monitor the flattening of the neck. That's the way we can tell if they are able to do the contraction and hold it. And it can be done virtually on the first treatment because it is so low load. They are lying down. So we look at that. I always look at the extensors plus the 𝐓𝐴𝐴𝐴𝐴𝐴𝐴𝐴𝐴𝐴𝐴𝐴𝐴𝐴𝐴𝐴𝐴𝐴 axio-scapular muscles. And then for the sensory motor system, I will routinely look at joint position sense. So that's where you will get the patients. We use a little laser light that we put on their head. So you look at them in their normal posture, close their eyes, get them to turn, ask them to come back to see if they can reposition accurately. So it doesn't take very long, it takes a couple of minutes, and I routinely test balance. Okay, and it's quite surprising. Even people without complaints of unsteadiness could often have poor balance. It's quite surprising how common that is. And then you can also do a quick test of eye movement control. So once you get experienced, I like to do that quick screen on every neck pain patient, on everyone. And once you get experience, you can do it in about 15 to 20 minutes, that sort of examination. But it does give you a very good basis on what you can build, to build that treatment program.
Yeah, that's awesome. It's a lot of things to pay attention and screen when you're doing your assessment, and that's gonna tell you how you're gonna manage, right, each condition.
Yeah, and I think it's important that we look for patterns, because things don't happen in an isolated way. Like, you don't get a sore joint without the muscle system reacting. and you don't get a sore joint without the movement system being disturbed. If you've got dizziness, so it could be vestibular, but it could be cervical related. So you do these quick screening tests. And you've got to have a comprehensive understanding of the patient to really do best practice treatment. If you've noticed, if you notice, I haven't spent a lot of time on things like trigger points, because to me, trigger points are secondary. They're very painful. There's no doubt about that, but they are secondary. Like, they're secondary to a pain syndrome. So I think you've got to look at function first. I don't get fixated just on painful areas. It's more looking at function, because if you can restore function, that will decrease their pain. And often things like the trigger points, which on occasions may need localized treatment, but often they start to settle once you've got them functioning well again.
And I was just curious to ask you about the posture that you mentioned in the beginning, that you look at the posture, and then how do you correct that? How do you manage that? Do you do like a muscle work? I know some people, they do like postural positions. Some people try to relax the muscles. So now you're going to start talking more about how you address probably each of these scenarios. So what would you do when you see that the posture is impacting the symptoms?
Okay, if it's their actual spinal posture, we correct it at the lumbopelvic area. Okay, so we ask them, to draw their pelvis up and literally restore their lumbar lordosis. And if they do that, that actually usually gets most of their spinal posture reasonably good. So we always start at the base to go up. To ask people to sit in that sort of posture all day, every day won't work. You can't do it. So what you've also got to make sure is the chair that they're sitting in and how they sit in the posture, make that as good as possible. And then we use a posture correction exercise as an exercise to be done, say, 2 to 3 times an hour, so that we get them to whatever they're doing. So if they're, say, working on a computer, they can just roll and sit up straight, basically, and they just hold the position for 10 seconds. In fact, a posture correction exercise becomes one of my most important maintenance exercises in a way, because we have shown actually in a study that if you roll up at the pelvis, that will activate your multifidus, which is a very important supporting muscle for your back. And then if you very, very gently lengthen the back of your neck, don't do anything other than just think about, I'm lengthening the back of my neck. We've shown that actually activates the longus capitis, longus 𝐏𝐴𝐵. And then if you ask them to just reposition their scapula, so if they've got a downwardly rotated scapula, they're going to pick it up and put it back onto their chest wall, and they just need to hold it for about 10 seconds. And what that does is that it really it activates those deep supporting muscles, and then you'll also get a relaxation often of muscles such as levator scapulae. Because that's where you get sore. You get sore in levator scapulae or sore in lower trapezius. But if you activate by correcting that scapular position, that also relaxes those muscles. We did a little clinical trial, by the way, to show that just by doing that posture exercise twice an hour for your 8-hour working day was enough that it began to re-educate your longus capitis and longus 𝐏𝐴𝐵. So that's the sort of exercise I do, and that's one of the exercises. I make an analogy. It's almost like cleaning your teeth. So you say to the neck pain patients, they've just got to regularly clean, the joints and muscles of their neck. And if they just do that for 10 seconds, 2 or 3 times an hour for 8 hours, the clinical trial showed that was enough, that they can actually keep those deep muscles going. So I use that as a regular posture exercise. Yeah. You're never going to change a patient's shape. Their postural shape, there's so many factors. A lot of it's inherited. I've got very few curves. I'm flat, but I look exactly the way my mother looked, sort of thing. So don't worry about postural shape. It's more getting the muscles to work well in the posture you've got, I think. None of the treatments are complex. You've got to keep them simple and easy to do. You've got a better chance of compliance. If you make things very complicated, people won't do it. Yeah. And then in the treatment's got to be multimodal, basically. No one treatment, like education and talking to the patient about pain and education in work practices and all of that sort of thing is very, very important. If you just do that and nothing else, the evidence says it doesn't help much at all. Okay, pain education and nothing else, ergonomic education and nothing else doesn't do much. But common sense says that the patient must understand their pain, they must understand their ergonomics, so it's part of a multimodal package. And that's what we've got to stress. Multimodal treatment is the one that's important. Because, again, I can treat the joints very effectively with manual therapy, and there is evidence that you will get good pain relief with manual therapy. But if I don't re-educate the muscle system, the joints are going to get strained again. So that it's the multimodal. When I treat a neck pain patient, I'll talk a lot and discuss a lot with them. I'll also spend time making sure they do understand, and work practices is very important. I'll use manual therapy because it's very, very effective in relieving their pain. But from day one, I'll start re-educating their neuromuscular system as well. So I'll start to re-educate their deep neck flexors. I'll start to re-educate their extensors with a bit of a focus on their deep neck extensors. And then if they have got sensory motor deficits, you bring that in. So and as long as you bring that in the first or second treatment, it doesn't matter if it goes over a couple of treatments to introduce it all, but it is very important that you address each system, because we've actually also shown that it doesn't, just because the pain goes, doesn't mean that the muscle function comes back. In fact, it doesn't. It doesn't come back by itself. You've got to exercise and re-educate those muscles to work properly again.
Because then you're probably going to have a recurrence, right? If you don't re-educate these muscles, at some point the pain is going to come back, or...
Absolutely 100% correct. Because if we look at neck pain, and that's the problem, that often we look at just the episode, and if the episode gets better, we say discharge the patient and everything's okay. But if you look at neck pain is a recurrent disorder. So once you've had one episode of neck pain, you've got a high possibility that you're going to get other episodes of neck pain. And sometimes they almost go over your lifespan. And so the real challenge for physios as rehabilitation experts is to really try to decrease that recurrence rate, or to decrease that transition into chronicity. And the tools we've got to do that are our therapeutic exercise, as well as our education. But be assured, we often get this fixation on pain, getting their pain better, and that's what the patient wants. And if you look at our clinical trials, a lot of the outcome measures are the VAS, the Visual Analog Scale for pain, or the Neck Disability Index, that questionnaires on the patient's pain. But just getting rid of the pain is only part of the solution. We've really got to rehabilitate them, and we do it in the peripheral joints. I mean, if you have a footballer who hurts their knee, for example, you just don't do something to get rid of the pain. You really rehabilitate his muscle system and his proprioceptive system to prevent recurrences. Well, the neck is no different. The neck's no different. You've got to really rehabilitate them. And so with all the patients, I give them a maintenance program. And I try to make it simple, so they've had a home program because they must exercise, they must do the rehabilitation strategies that you've prescribed. But I also make sure that they have a maintenance program. And as I said before, it's got to be simple. And so the main maintenance program is to just do that postural correction so that I know they keep activating their deep muscles the whole time. And then a mobility exercise. And I ask them to pretend to shoot a bow and arrow. So they practice archery. And if you look straight ahead and you pull a bow and arrow, you get a very, very good rotation mobilization. So I get them to do those two simple things as their maintenance program because neither of them take much time. And then the other thing too is that people can feel if their neck's starting to get a bit sore again. And so that I also teach them or talk with them about a relapse prevention program. So if they feel their neck's starting to get a bit sore again, they should go back to the exercises, whether they're muscle facilitation, proprioceptive exercises or whatever, you would have known which things help them the most. And so get them to do that, start that up themselves. And if that doesn't fix it, they should get assistance quite quickly, because if you can treat them once or twice, you can often stop that episode coming on. So it's not only treating them. The main things is that it's a multimodal program, that rehabilitation of your neuromuscular sensory motor system, very important because they don't automatically get better just because the pain goes. The research has shown that people in between episodes still have those deficits, so they must be rehabilitated, and then get them on a maintenance program and also a relapse prevention program. I think it's pretty important.
And I wanted to ask you, what do you mean when you say re-educate deep muscles when you're treating the patient? So is just them being aware of activating these muscles, or do you do strengthening per se? Like, how does that work?
Okay, so what the exercise program involves is, first of all, you've got to make sure they work. So that we do two phases really of the exercise programs, because they are inhibited, they don't know how to work properly, and they do lose their strength. So, but in the first part, I'll just train craniocervical flexion. So that can even be in line with the patient actually just practicing how to do craniocervical flexion, because a lot of them also are not proprioceptively aware, so they don't know what to do. So we get them to train to activate and to also build up their low-level endurance. So we get them to hold for 10 seconds. I reinforce that during the day because they start that posture exercise, with sitting up straight and elongating the back of the neck. They start that from day one. So they do some formal practice of craniocervical flexion, and then in the morning, and then they repeatedly activate those muscles during the day. And this is where it's important. We've got this test with the biofeedback where that's important, because a lot of your neck pain patients, basically the test, we inflate the bag to 20 millimeters of mercury. They nod, and they've got a nod to 22, 24, 26, 28, 30, which basically takes them through increasing positions of inner range. What we find with the neck pain patients is they usually can't do more than 22, 24, whereas your normal people can do 26, 28, 30. So they've got to train to be able to hold it. And we recheck them when they come in. So they get the feeling of it in the practice, and then they go home and they practice feeling that contraction and holding it, and we use the eyes to facilitate. And then once they can get to about 26 or maybe 28, Then you want to make sure that both muscles, the deep and the superficial layers, can work together well. And so that's where you might start some of your very gentle head lifts where they've got to control their chin. So you progress. The other research has shown is that you do need specific exercises for specific dysfunctions, so that if you just did head lift exercises, it doesn't re-educate the deep neck flexors. You've got to take them out of function and make sure they work, and using the craniocervical flexion action is the easiest. We also, it's similar for the extensors. We can't separate the layers. We can separate the layers of the flexors with the craniocervical flexion action. We can't separate the layers of the extensors so well, because the minute you put the head in an anti-gravity position, all muscles will work. But what you can do is, if you get the patient to extend, they keep their craniocervical area in neutral and then practice extension, not lifting their chin, not retraction, actual extension, it actually biases their deeper muscles. So all muscles will work, but it makes the deep muscles work. That doing it without craniocervical extension. So we get them to practice their extensors that way, and then once they can do extension up to about 20-30 degrees, controlling their chin position, then we'll change it to a strengthening. So the therapeutic exercise really is to look at the deep muscles first, get them working, and then once they start to work, you integrate them with the superficial muscles, and then you've got to look at strengthening the whole system. It's probably not easy. Easier to demonstrate than to talk.
Yeah. So I remember you said about the movements before that you feel like is the root cause of the pain when you're talking about the assessment, the joints. So when you talk a lot about the muscles, do you feel like the joints are usually the ones responsible for the pain and the muscles for the main things? Like how do you feel it's like, what part are the muscles and joint responsible for the pain?
I think the root cause is most commonly, probably not always, but is most commonly the joints. So when you've got joint pain, joint inflammation, swelling, you get inhibition of the muscle system. Okay? So there's reflex inhibition, there's pain inhibition. So the muscle system, because of the painful joints, becomes inhibited. And so you then don't have proper muscle support of the joints. And the muscles themselves, some muscles, if they are guarding and hanging on, they themselves can become painful doing that. Okay, so for example, some of them can become painful just from their guarding or overworking or whatever reason. But I think the joints cause the muscles to become inhibited. And then if the muscles aren't working properly, the joints aren't supported properly. And so it just reinforces that pain cycle. Because we have shown, we did a big clinical trial on headache. This was quite a while ago now, but it was a 4-arm trial. So we had one group who just received manual therapy. We had another group who just received this motor control exercise, another group who received both, and a control group who had nothing, basically, no physical treatment. What we were able to show was that if you just looked at their headache and pain, that the manual therapy helped them. That group got a lot less frequency of headache. The same happened with the exercise group. So by rehabilitating the muscles, we actually settled the joint pain. But if you gave them both, you got about 10% more patients better than doing them separately. So either your manual, if you're just thinking of the pain in that, Manual therapy can help, the exercise can help, but it's better to put them both together. But what we've got to think of all the time is rehabilitation. The muscles will inhibit, joints will inhibit the muscles, and we've got to remember they do not automatically get better. I mean, if you think of the knee, it's often quite hard to get that quadriceps and the VMO back again. So the patient can, their knee pain can get better, but you've still got to, their VMO is still not anywhere as good as their unaffected leg. And we've shown that in the neck as well. 𝗏𝗶𝗱𝗲 from Birmingham's done a lot of study recently on looking at people when they haven't got neck pain between episodes, and she's showing that these deficits are clearly there in that remission period. So we've got to remember we've got to decrease their pain by whatever modalities that we've got, but we have got to rehabilitate. We've got to make the muscles work normally, the same as we would if we were rehabilitating a knee or an ankle or whatever.
Yeah. And I think the challenge is how you're going to measure that. I think it's probably really hard to measure the muscles.
No, that's true. That's true. But the craniocervical flexion test, I can tell, because I will train the patients till they can do the perfect nods up to 30. So I can tell, and it's important that you bring up a very, very good point, because it's very important to reassess the improvement. So I can bring that, you can do the craniocervical flexion test and reassess that you've properly rehabilitated those deep muscles. With the extensors, again, once they can extend their neck, say 10 times to 30 degrees while their craniocervical is in neutral, that gives you a very good indication that their deep muscles are re-educated. I mean, we've got no fixed value of strength that we want to get them to. So we, that is the problem. There is no absolute strength value that they should get to. But again, you would improve. You've got to say improve it by 30% or whatever your goal is on how weak that patient is. But do keep reassessing. I mean, joint position sense, it's an objective test. You can do that. Balance, you're looking that they can, say, stand on one foot for 30 seconds. That's quite normal for your middle-aged patients. It gets less as you get older. But there are absolute values that you can head for in those sorts of situations.
Yeah, very good. I mean, it's a lot to unpack here. I wanted to ask you about the sensory motor program, but I don't know if you want to maybe just quickly tell us, or walk us through, how do you rehabilitate that?
You would assess what thing is most affected. So let's just take the example of proprioception. So their joint position sense is poor. So we would start putting a laser, just a laser on a headband, and with their eyes open, they would practice, for example, turning and coming back and feeling what the normal is. So they'd practice first for several days or however long it takes that they practice with their eyes open. Then they might practice with their eyes closed, and then they can come back and check how accurate they are. And then it's like the muscle system. You've got to add load. So we load the sensory motor system. So, for example, they might practice with their eyes open and then closed in sitting. And then I'd stand them up and make them practice in standing. Then you could ask them to stand on one leg to make the system more unstable and work harder. And so they'd practice relocation standing on one leg. I mean, the balance programs for neck pain patients is the same as your balance program for any other condition, basically. You might start on two legs, eyes closed, progress to tandem stance, eyes open, eyes closed, progress to 1 foot stance, eyes open, eyes closed. So as long as you just keep loading the system, it's not hard to progress. And there's Yeah, Julia Treleaven's written quite a lot about the rehab of the sensory motor system.
I wanted to transition to the final questions because I know we have a lot to talk here. We could stay hours talking about this. So if people want to learn more about that, I know you have a lot of resources. Why do you recommend people to go to learn more about this topic?
This sounds bad, but in our text, we've got that text, the management of neck pain, a research approach. And then you can easily get it on Amazon, but it really does, it gives some of the theory background and what's happening in research. And then it does give several chapters on assessment of each system, as well as the treatment of each system. So if people are really interested, it's quite a good resource, published in 2019. The other places, I'm lucky because I have access to a university library, so I can get whatever articles I want. But if people are interested in systematic reviews, the Cochrane collaboration, that's free, that you can go and get it. I don't know if you know of PEDRO, PEDRO. It's a database, the clinical trials for physio. And again, many of the articles there will have the abstracts, but you can find out, treatments for certain things. But the other one to use is Google Scholar or PubMed. The Google Scholar is probably the best. And you can always get if you type in what area you're looking for, you'll at least get the abstracts of the articles. And there's a lot of open access journals now. So a lot of them you can look at the whole paper through Google Scholar. So the textbook, it sounds nasty to promote my own book, but it does give a very good summary, and the authors are myself, Julia Treleaven, and 𝗏𝗏𝗲𝗏, and Sean O'Leary. So we've all done contributions to different parts, so it's quite a comprehensive text. And it's all in one place, which makes it easy.
Yeah, very good. And what would be the best advice you give to clinicians that are starting their careers?
Well, first of all, I think it's important that they like their job. But, they've got to like people, like their jobs. They've also got to have a passion about helping people, I think. I think they're all very essential qualities of a physio. To also realise that when they start, that probably the first year or two after graduation, they will learn twice as much as they learned in their undergraduate, in their qualification course, and that there is an awful lot to learn out there, and so it's to be keen to continue with their professional development, I think. But mainly they've got to love what they do and like people. I think that's very, very, very important. And I found treating patients, getting people better really excited me. It's the job satisfaction part of it is very important as well. And if you know your work and it is motivation. They got to like problem solving and puzzles and all of that sort of stuff. Yeah.
And what personal qualities and abilities that you think are important to become a successful PT?
Well, as I just mentioned, I think you've got to like people because you're dealing with them and you're dealing with them in very close contact. I think it's very important that you have empathy with them. Being in pain is not nice. And so that you've got to show the patient that you understand and you've got genuine empathy with them. Other qualities, as I said, you've got to like problem solving and like challenges. And I always treated every neck pain patient as a challenge. And it was a challenge to my intellectual skills, my problem solving skills, and my clinical skills, and to remember that it's all right to say do manual therapy, but if you're no good at it, it's not going to make the patient better. So I think everybody's got to strive to make sure their clinical skills just keep improving and improving and improving. Never be happy with your standard. You can always try to do better. But mainly just enjoy the career. I think physiotherapy or physical therapy is a great career, and I've certainly enjoyed it.
Yeah, absolutely. And I know we talked a lot about a lot of different things. There is anything else that you want to say to kind of like wrap it up before we end the conversation?
I would just, I think, mainly to think about neck pain as a recurrent disorder. And our biggest challenge, which we haven't conquered yet, is to prevent recurrences or to try to decrease that transition to chronicity, because that, in fact, is the greatest challenge. And we haven't, or nobody has met that challenge yet. So don't think of it as the one episode. Think of it as a recurrent disorder, and you are rehabilitating to try to decrease recurrences.
Yeah, not just treat the pain, but try to get a maintenance program, something that they can keep working on to try to prevent neck pain. Yeah.
To think rehabilitation. We physical therapists are rehabilitation experts. So we've got to keep thinking rehabilitation, not just pain relief, rehabilitation. I think that's probably one of the main messages.
Awesome. And if our audience wants to learn more about you or contact you, is there a way that they can find you?
Actually, if they look at me on the University of Queensland, if they put my name in there, that will bring up my curriculum vitae, contacts, that sort of thing. They'll get it all there. They can see my publications and the work that I've been done. So if they just search me on the University of Queensland webpage, that's probably the easiest way.
Awesome. Well, Wayne, I appreciate so much you taking the time to share all these years of experience and research and give us here some insights and tips to help us when you're treating our patients and improve our care. So thank you so much.
My pleasure.